cover during this block. A lot of people, and I think, enjoy the upper and lower extremities better. Doesn't mean there's not stuff to learn and memorize, but I think it's relative. Like if I said, well, if I was coming to PA school to study anatomy, I'm like, what will I probably study? You would picture that you're going to study a lot of upper and lower extremities. We have a lot of those injuries in the military, that kind of thing. And you're right to an extent, but it's a whole medical process getting through here. So the reason I say that, people find this a lot more interesting, especially when we get to test 7, and about half of you will calculate what your grade is and go, wow, I don't even have to take this one. They may have already done that, I don't know. But I will tell you this again right before test 7. Remember that treat every test like it's the one that's going to get you? Because statistically that may not get you, but that can come back to haunt you later. Always finish course strong. What's the info you need to know? You're letting you blow off the last test, you're just letting yourself down. Because somebody's going to want you to know that later. Anyway, okay, enough seriousness. Let's get that upper extremity. I like upper extremity, I love lower extremity. So, I don't really like all the holes in the head we had to go through yesterday, but y'all did really well. What's that?
But they were on there.
They were on there. Y'all didn't miss many holes in it. Y'all did great yesterday. Alright, I know, every time I say it, in my opinion, you did. Alright, functions of the upper limb. I will always, you'll hear me compare and contrast the upper and lower extremity a lot, because they're very similar when you look at like the shoulder girdle versus the pelvic girdle, when you look at the ball and socket joint that we find at both areas. But what we're going to see is the differences is we manipulate objects and things, right, using our upper extremities a lot more than we do with our lower. But when we get to the lower, it doesn't have to manipulate things so much, but it has to be able to support your weight, locomotion, that kind of thing. So we look at all the differences associated with them and why we might injure it. When you look at the lower extremity versus the upper extremity, you have falls and stuff. A lot of times it's not your lower extremity that's going to get hurt, unless you're elderly, right? Nursing home elderly fall, that's not good. But the upper extremity gets injured a lot because of like foosh injuries, which you know what a foosh fall on an outstretched hand. You heard that before? I can talk a lot over the slides, but I like this one. When you look at the upper extremity, you have the shoulder, the arm, the forearm, and then the wrist and hand. So we separate these. I need you to start. This is where I'm going to start telling you. I do this different than other anatomy classes. Not really that different. I didn't recreate the wheel or something here. I'm saying we're not going to learn, or we're not going to test on the origin and insertions, but we are going to learn them, as in go through them, so that we have an idea of where those are at, because it helps you, because what I'm going to expect you to know is each muscle we talk about action and its innervation. Okay? So the way we're going to do that is compartments. So I don't want you to ever get confused and start thinking, when we look at like the arm from the shoulder to the elbow, elbow to the wrist is the forearm. Divide that in your mind the whole time, because a lot of us will say, well, raise your arm. Well, we'll raise our arm. We picture that as a whole arm, even though we know this is called our forearm. But I'm trying to help you out when you're going through like a 50-question test in one of these classes. There are muscles that sound very similar that are in the arm versus the forearm. What I'm trying to tell you is make sure when you're answering any questions on a muscle of the upper extremity, if you can't underline it, highlight it or something, go, oh, it's asking forearm, or it's asking arm. Because when you first start learning them, they sound the same. You're like, was it in the arm or the forearm? Because I'm going to teach you all of these by using compartments. So as we go, we won't get into it today, but as we go through it, we're going to learn the shoulder, girdle, all that. And then when we get into the arm, we'll really start to see, okay, the anterior compartment of the arm has these muscles. They do these actions, and they're innervated by which nerve. And one of the good things I would think to do is, it helps to have that chart that I made for you on the muscles with its action and innervations, so you can not stress so much. When you look at that, you can look out there and go, wow, look at all these muscles that are in the forearm. And then you look out down the side of it, that chart, and you can see, well, almost all of them, but 2 in that compartment are the same nerve. So it decreases rather than studying them one by one. This will make a whole lot more sense as we roll through it. Okay. So to start with the pectoral girdle, that means your shoulder girdle. That specifically means your clavicle and your scapula on each side. So the pectoral girdle, even though it's has attachments, muscle and ligaments to the thorax, is considered part of the upper extremity. So it's part of the appendicular skeleton. When we look at the pectoral girdle, we're going to see that a lot of it is held in place by muscular attachments, specifically on the back. Sorry. So I just, a basic picture showing the thoracic cage again, but that you have your clavicle out here, and then your scapula. So we need to figure out all the landmarks and what attaches or comes off of, inserts into that clavicle, what helps stabilize it. And so we're going to look at the bones first, because every bone has landmarkings, and those landmarkings are important because that's where things go. So if you look at a clavicle, it's lying horizontal. You know, we all kind of know where our clavicle is. And its job is going to help stabilize the pectoral girdle by having an articulation with the sternum and with the clavicle. We'll talk about specifics where they attach or articulate here in a minute, but that's your clavicle, and it's kind of an S-shaped bone, and it's very frequently fractured, specifically when people fall, like older, you know, kids fall and have a Fuchs injury. A lot of times they break their forearm, or they break the wrist or something. You know, you're worried about scaffolding, but they don't generally drive that force all the way up into the shoulder. But a lot of adults, football players, military, you know, they'll drive that force up there, and that actually can fracture that clavicle. Like I did when I was a kid. I ran smack face into a, y'all don't go to skating rings, but back then we did. And I was showing off. I'm admitting it. See, I tell y'all too much about myself. But I was showing off, but it was on the carpet area, not on the floor. And I ran smacking, and they have these walls. They still have those if you've been to a skating, and they're like this high, and they're just, who thought it's a good idea? Let's put just concrete there. They're just cinder blocks. And I went straight into that and broke my clavicle. It was awesome. I didn't know I broke it till later. They didn't care anyway. They don't do anything for you. You know what they tell you when you break your clavicle? Suck it up. Essentially. Yeah, unless it's displaced or something. Who's the technicality guy back there? I'm just kidding with you, man.
I played rugby in high school before I was in the Army, and one of my teammates, you know, broke his clavicle during a game, and like, she actually had to get like a titanium plate.
Oh,
It
really?
was like right there in the middle.
Cool. I didn't mean that. I wasn't being sarcastic. Now you gotta make me explain that. I'm gonna give you an analogy for this scenario. You're in phase 2, and somebody says, hey, over in the ER, they got a guy whose clavicle is like this, sticking out of his chest or something. Guess what you're going to say? Cool. You don't talk like I do. You're going to go, cool. Hey, I'm going to leave clinic for a second and go look at that. That's what everybody, that's cool. Because that ones I've seen are just kind of, but rugby's a tough sport. I don't play rugby. I was saying, I used to have a rugby shirt a guy gave me. I got kicked out of a mall in Hawaii for wearing it, so I had to leave. It said, I'm going to tell you what it said. Makes me sound like, rugby guys are pretty crude, right? It said on the back, in letters, it said, F.U. we're from Texas. They wear, if you don't know rugby teams, it fits right into that. Okay, clavicle. S-shaped bone with 2 curves. If it's going to fracture, it's going to fracture in one of those curves. And we're going to use ligaments to stabilize it in place. So that means we have to learn those ligaments. There are 2 different ends. You have the acromial extremity, which means it's going to articulate with the scapula. And then you have the sternal extremity, which is going to articulate with the sternum. One of the first things we start to look at for the landmark is called the conoid tubercle. And this is a site of what we call attachment for a portion of a ligament. So there's a ligament called the corticoclavicular ligament, which is actually two separate ligaments. So I don't know why they didn't just name them. Well, they did name them two separate things. You know, in other words, we have a conoid ligament and a clavicular ligament. Then they try to confuse us and go, yeah, but that's actually the corticoclavicular ligament. I don't just leave it at two. We got it. But I'll show you what I mean in a minute. Hey, scapula. We're going to go through every landmark on this scapula, kind of denote what we're talking about. His job is to articulate with the clavicle and the humerus. Remember, we're going through musculoskeletal now. Every time, if you want the right thought process, and I talk a lot about this because I think it helps you all to pick it up. One of the things we always want to look at is, we say in articulation, we kind of want to know like what muscles cross it, or what is holding that articulation together everywhere we go. In the same regards, keep this in your mind, especially when you're answering any questions on musculoskeletal. So we're not going to learn origin and assertions, but you need a visualization, because if you know a muscle crosses a joint, whatever joint that might be, if you think of its action, it probably has some action on that joint. And so that helps you when especially when you're just working through a list of things, to go, well, yeah, I know that originated above the glenohumeral joint and it goes down here. So it crossed this joint, so it probably has action on that glenohumeral joint. Or maybe it crossed the elbow too, so it probably has action at the elbow. Okay? So always think about that when we look at these. Yeah. We'll look at how it's held on in the back in a second. The acromion is the highest point, most lateral point of the scapula. And if you are looking at like a tailor, that's that high point. Not everybody's is as prominent. The skeleton is not. This is your acromion out here. But when you feel it in a person, it's like a bump up there, right? That's your acromion. That's where they're going to measure from there to your wrist to fit you uniform. The glenoid cavity is this depression that we find here. That's the glenoid cavity. So the glenoid cavity, you would say, accepts the head of the humerus. So if we look at the humerus, I go to the skeleton a lot more than previous class. So the glenoid cavity is very shallow. There's not much to it. It has a labrum in there, and it accepts the head of the radius. It accepts the head of the humerus there. And we'll look at how our rotator cuff helps hold that in there. The thin edge of the scapula is going to be close. I have all these color coded to show. If you look at the medial border of the scapula, it's also called the vertebral border because it's close to the vertebrae. If you turn around and look at if you need me to turn the skeleton around, this is your medial border, and they call it the vertebral border also. I forgot about y'all. The vertebral border because it's closer to the vertebrae. And it's much thinner than the other side of the scapula. When we get into the lab and look at scapulas, you'll see they're a lot thinner than you think. To me, they actually look like one of those dog rawhides that you throw them. The thick lateral border, down towards the axillary region, so that's the axillary border. And then where they meet at the bottom is called the inferior angle, down here. Right? If we have an inferior angle, that means in red here we have a superior angle. And then across the top in green here we have the superior border. So you would say the superior border meets up with the medial border at the superior angle. One of the things that we see at the top of the scapula is this little notch here. And it's over here too. And it's on the skeleton. That's called the suprascapular notch. And what goes through there is the suprascapular nerve. I'm going to leave it at that for now, because I'm going to cover that. But suprascapular nerve goes through that. You also have the coracoid process. They call it the beak, crow's beak. Doesn't look like it to me, but if you see it's kind of, looks to me like a hammer toe. We call it the hammer toe portion. We'll get to that in the lower extremity. But if you come up and you find the point, you say, well, this is the highest point, that's my acromion, or really your AC joint, right? And you reach down here, this little projection here, that's the process that looks like the beak called the coracoid process. So it's harder to see on the screen. So if you're going to confuse anything on a labeling of the scapula, it's always the acromion and the coracoid. Because they're close together, people mess that up all the time. We're going to see that most of our rotator cuff, well, all of it, right? All of it, the muscles that are a part of our rotator cuff, originate off of the scapula. So the scapula is helping to give them an origin point. And so up here at the superior portion of the scapula, this is where we would find the supraspinous fossa. That's where supraspinatus will originate. And then down below the scapular spine there, that's the infraspinous fossa, where infraspinatus will originate. I want to mention, if you look at, if you're orientating a scapula, you always look for, can you see the scapular spine? Because the scapula looks kind of similar on the front and back when it's not on the body. This is the scapular spine. So if you can see, like in the left picture, or right picture there, that's the scapular spine, and you know you're looking at the posterior side of the scapula. Because on the anterior side, it's just one big fossa called the subscapular fossa, where subscapularis originates. All three of those are part of our rotator cuff. So we're going back to that notch. This notch has a ligament, right? That's the suprascapular notch. And it has a ligament that goes across it. Now, sometimes we have the specimen up here that still has that intact, but not always. Most of the time in the cadavers that we have, we don't see that anymore. But that ligament is just called the superior transverse scapular ligament. There are a lot of different ligaments that may sound like superior transverse, but they define it and say, well, this is the scapula, so we know it's on the scapula. So that's going to convert that, in this case, into a foramen. And what we know about foramen from last class is anytime you have a foramen, things are going to go through it. And we said the suprascapular nerve will go through that area. And where it's going is to innervate supraspinatus and infraspinatus. So let's orientate this picture to help y'all. Once again, I look on there and say, well, that's obvious. I'm going to talk about some things that are on it that we still haven't covered or haven't covered. Get you familiar with it. So out here is our acromion. And here's our coracoid. When you look at this area, this is your clavicle. And so we have the coracoclavicular ligament. We'll talk about them again here in a second. And that's what we find here. And then we have suprascapular notch. Another way that you can orientate a whole picture like this, the first thing I would look at, anybody pick out, what can you see on this picture that tells you this is an anterior view without even knowing? Which, this? Well, yeah, you don't see the part of the spine, I agree. Specifically, I would look at here. What do you think this is? I know I'm being unfair because I haven't taught it, right?
It's the biceps tendon.
Yeah, it's the long head of the biceps tendon. And as we'll see in future slides, the long head of the biceps tendon goes through a groove in the front of your humerus, the intervertebral groove. It has a lot of names, bicipital groove, the long head of the biceps. But here what we see is, as it gets to the glenohumeral joint, it enters the capsule of that shoulder joint. And so if you can see the long head of biceps brachii, you know you're looking at an anterior view. Maybe too much for now because we're building, but okay, so here's a good picture actually once you figure out the orientation of the superior transverse scapular ligament. So this is the ligament This is a metal probe. And then we see this suprascapular nerve going right here. So we can kind of see, you can't see this side, but it's going under that ligament. And what it's going to do is, this is the anterior view, so that nerve comes anteriorly and goes through that area. I'm going to back up just to show them. And as it comes through the posterior side, it's going to come through that suprascapular notch. It's going to innervate supraspinatus, and it will also wrap around the spine and come down here and innervate infraspinatus. You don't have to write all of that there. I promise you, we're going to mention that several times, but I feel like I'm building it. So one of the other things you see in this picture is the suprascapular artery, and the probe is underneath it. But notice the suprascapular artery is going over the top of this ligament. And so there's a way somebody came up to remember it, is that when you talk about suprascapular nerve versus artery, they say, well, the Army travels over the bridge, the Navy goes under the bridge. So the nerve goes under, the artery goes over. If you're wondering why we're talking about it, it's because in the military it's a little more common. You don't often see it, I guess. I don't see it that often. They say it's more common because of traction injuries, fast roping, too heavy of rucksacks, that kind of stuff. And you can develop suprascapular neuritis, which is just another form of nerve entrapment, neuropathy. And so at the back of the shoulder, that nerve where it goes to that suprascapular notch can get injured, especially with like a traction injury. Yeah.
This is like a curiosity question, but arthritis at the AC joint, is that the only arthritis in the body that can be treated with surgery without replacing the joint?
Lord, I don't know. How do you ask these questions all the time? I love your questions. You made me go home and think. I don't do a whole lot of that ortho in that area, but I've never heard that.
Well,
Where did you?
orthopedic. So I know that you can get a distal clavicle resection to like treat the arthritis. But I was wondering if there's other places in the body where you can essentially do something similar without replacing the joint itself, like a shoulder replacement or a knee replacement or hip replacement.
Yeah. So do they go in there and clean that up? What do they do to the AC joint?
They just go out there and cut like maybe half an inch to an inch off the distal clavicle where it meets the acromion, and you're just like good for the rest of your life essentially.
They call it like shaving it.
Yeah.
I mean, they shave the knee joint down. Like you do a scope and shave down the bony articulation after arthritis is built up. They do kind of that same thing there. I've never seen it done at the AC. I mean, I'm sure it happens all the time, but I'm just not in that field all the time. I did take a CME though. Don't you say it on reverse? What is it? I don't even remember. I obviously didn't listen. Something about reverse shoulder. Anyway, these are old people. I don't listen to CMEs very much. No, I appreciate it, man. I just don't know enough about it.
Yeah. Thank you.
What was that? Oh, supraclavicular neuritis. If you see this, right, it's probably going to be some type of overhead traction injury, and we don't test. I don't test clinical findings, but I throw them in there sometimes. You start to see neuralgic pain that's going down and radiating through the C5-6 dermatomes. So out on the back side of the arm, you start to see those people. One of the examining ways you can do that is to put pressure and find that suprascapular notch the best you can, or get close to that area now that you're familiar with it. Put some pressure in there and see if it recreates their symptoms. You're going to do these more than you think, because especially like on deployments where you don't have to write these huge notes, and somebody comes in, a gunner comes in off the truck, says, man, my shoulder's been killing me. All right, so what have you been doing? Talking to them, and then you ask, do you get the weight sets that they have over in the other building? Because they often have weights now when you're deployed out there. They're like, oh yeah, every day. And you can talk to them. Most of those gunners, when I was there, when they take that heavy body armor off in Afghanistan, they would grab it and just pull it over their head. Which makes me think of the Army combat shirts they sent us in Afghanistan. And you sweat in them, and when they would pull, the first time they pulled them off of that after being in the truck for 6 hours, It just ripped the whole shirt off. It just ripped with it anyway. They get shoulder problems from that, right? And they're in there lifting. And one of the other ones you'll do is we talked about the biceps. It's one of my favorite, but it's very diagnostic. I probably wouldn't do this in a civilian, but a lot of times I'll just grab them by the shoulder and go, is it right here? And just dig your thumb. Like, you ever done pressure points on somebody, like when you're wrestling, or I do that like a pressure point and just dig in there, because they're not gonna be happy if it's bicep built in it. Civilian, you're palpating. How's that feel, right? That's sore? I'm kidding. I was about to lie. I'm not kidding. I really. There, right? Okay. We always say it at the end of entrapment things. If you entrap a nerve long enough, obviously you're going to develop atrophy. That numbness and tingling will turn to atrophy. If you've ever seen somebody with like carpal tunnel syndrome, that group of muscles will start to waste away. That will happen anywhere that you entrap a nerve for a long period of time. Alright, before we switch to this, I read something today, and I'm losing track of the military, and I realize that, even though I'm with y'all all the time, so I rely on y'all for a lot of things. Because I know what the expert, combat medic badge is, and I know you can get a combat medic badge. What's a master combat badge? So if you have both now, instead of wearing them both, they just give you that one?
You wear the CMB with a gold wreath around it. Same with the EIB and CIB. If you have both.
So you don't
I wear the combat one, but you have the gold wreath to show you have both.
see, that's a great, when did they come out with that? Okay, so I'm not that far, it's not that bad that I don't know that. Because I'm like, well, I have both, but I would wear the EFP. So I would wear that instead if I had both. I like that. But why, y'all know why I would wear the EFP, right? Because I earned that for doing something. The other one, I just was employed and got shot at, That's, anyway, I didn't mean, whoa, I didn't mean to devalue those. Yeah.
Roll today.
My personal thoughts on it. If you have a CMB, I'm very glad that you were there and did your duty and I'm glad you got back here. But, I don't know. I was always that person, I'm gonna get started. I was always that person. I don't need, let's say this and I'm rolling right into this fight. I do not need another piece of paper reward for doing my job. Okay. If I do something special, I didn't break my own rule there. If I do something special, great. We don't have any Coast Guard in here this time. If I'm in the Coast Guard and I save 168 people or whatever, did you see that guy? You didn't need to read the whole story, he dropped it anyway. Okay, here we go. Articulation of the pelvic girdle, or pectoral girdle. The clavicle, we said, articulates with the manubrium at the sternum, but now we're going to say, okay, well, we got to name that. So that is the sternoclavicular joint. That happens just above the first rib. That's how we always identify that first rib. So you have a sternoclavicular joint on each side. When it articulates laterally, it's going to articulate the scapula. And so the scapula has two articulations. The shoulder is a little more complex than we think about it. We're going to separate the joints of the shoulder in the way we talk about them. And so where the clavicle meets up with the acromion, we just talked about, is our acromioclavicular joint, or AC joint. So we have a sternoclavicular, acromioclavicular joint, and then we have another articulation with the scapula is where the head of the humerus articulates with the glenoid cavity, right, where this metal sucked in. So that's the glenohumeral joint. And there are actually different motions and ways that you can measure these we're going to talk about. So the pectoral girdles don't articulate really with the thorax so much other than the sternum. If you look at the clavicles, yes, they articulate with the sternum, which is part of the thoracic cavity, but the rest of the pelvic girdle pretty much does not. Because the scapula and clavicle are not considered pectoral girdle, and once we get off of that sternoclavicular joint, and we get out here to this AC joint, that's fully out into this pectoral girdle, and all of that's held down by muscle. So the large muscles that we find surrounding this area are going to help to stabilize that. So go back to pictures here. Once again, this is our sternoclavicular joint on each side. It is a synovial joint, and it's specifically a saddle joint, synovial saddle joint. It's the only true synovial joint that we see up here. It just means that it has a little more motion than the other joints. So there's a lot of joints, but not all of them are synovial. Anytime you hear synovial, think it has a synovial membrane, and it generally has a little more motion. And that makes sense, right? If you raise your shoulders up and down, that clavicle is really moving at that joint. And I don't know if the skeleton will do that, but because they had to tack this down. But if there's no metal holding this thing together, you're going to see a lot of motion at that sternoclavicular joint. Kind of a good picture showing, right? Here's your manubrium, part of your sternum. Here's your sternoclavicular joint. Here we have the suprasternal notch or jugular notch that's right up there between them. Another good thing we can see that we're about to get to is our coracoclavicular ligament, which includes trapezoid and conoid there. That's these ligaments here. I'll come back to that. So the AC joint, where the clavicle meets the acromion, or where it articulates there, is considered a joint of the upper limb. Yeah, because the pectoral girdle is part of the upper extremity, not the thorax. It is a synovial joint too. It's the site where we have shoulder separations, as we were discussing, where especially you see football players, things falling down, separating their AC joint. And what's going to help stabilize that is that you have that acromioclavicular ligament. It's at that joint. You also have a couple of other ligaments in that area called the coracoclavicular, the trapezoid, the conoid. We come back to here, we'll see that here is your AC joint, acromioclavicular joint with its ligament there, and then you have the trapezoid is the most lateral ligament, and the conoid is the medial ligament on each side. And collectively, we said they're called the coracoclavicular ligaments. So they're helping to stabilize that clavicle. So the other thing that helps to stabilize it out here is the sternoclavicular joint. And I didn't bold it, and you don't need to know it, is there's also a costoclavicular ligament that's below that I don't circle that. Here's a blow up back to this picture of your AC joint, your conoid and trapezoid ligaments. And then this one I do want you to pick up on is this is one of your study pictures for sure. This is a coracoacromial ligament. So going from the coracoid process to the acromion. So AC joint up here, and its capsule, the coracoacromial ligament, and then these two, trapezoid and the conoid, are what give all that stabilization there, at least ligament-wise. Now we're not going to get to the muscles just yet. I'm going to finish out, and probably the rest of the day, we're going to work our way down through the bones and landmarks of the upper extremity first. And then we'll come back and start adding some things in. Alright. So the upper extremity has about 30 different bones, not about, it does. First one being the humerus that we find here. Down in the forearm, we only have two bones, that's the radius and the ulna. And then when we get down into the, we get down into the wrist, we're going to have the carpals that we're going to need to learn. 2 rows of carpals there, then we have the metacarpals, and then we have a couple of different phalanges, your fingers. If we go back and look at joints, the first joint we have here is the glenohumeral joint, then we have our elbow joint, we have wrist joint, and when we get into the hand, we're going to see that where the metacarpals meet up with the phalanges, you have the metacarpal phalangeal joints. And then you have the interphalangeal joints between each part of the digit. Alright, so looking at the humerus, longest and largest bone of the upper limb, just like the femur is the largest and longest bone of the lower limb. It articulates proximally with the scapula, specifically at the glenoid labrum, then it inserts distally at the elbow with both the radius and the ulna. So it's going to articulate with both bones of the forearm. When we look at the head of the humerus, here's our glenoid cavity, our scapula, and then there's the head of the humerus, and that's called the glenohumeral joint. Off of this humerus, we also see there is a greater tubercle and then a lesser tubercle. In between them, anterior, is the bicipital groove. There are two different necks to the humerus. There is the anatomical neck. If we look at this dotted line up here, that's the anatomical neck. And then the other dotted line below the tubercles is called the surgical neck. So we got to come back to a humerus. If you look on a humerus and a femur, is you have this smooth articular surface that's up here. And then there's kind of a line and the bone looks a little rougher. So at that line, that on a humerus, the difference between those two, that is the anatomical line. So you can kind of see the blue up there. That's the smooth part that I'm touching. The surgical neck is down below the tubercles, so it's like here. Right? So you have to picture the humerus, when it breaks a lot of times, breaks near that surgical neck. Hence, surgical neck. And so that's where the fracture might occur. Right, so they gave this area between the tubercles a lot of different names. So the long head of the biceps comes down and goes through this groove between them. That's called the intertubercular sulcus. It's called the bicipital groove, the intertubercular groove. A lot of references to it. Bicipital groove is generally the most common one I hear. And then, like I said, the surgical neck's down below that. I already said that. Right, further down, kind of almost mid-shaft, maybe not that far, you have a projection that's called the deltoid tuberosity. And we don't see the deltoid here, but that is the insertion point for the deltoid. The deltoid is that large muscle that covers the shoulder joint. Okay, so we all can kind of reach out there and we know what our deltoid is up there. It has an insertion point about mid-shaft called the deltoid tubercle. After that, we get down to the distal portion. And yes, you can touch yourself during the exam, like I'm doing. I told y'all the story about the guy, right? Asked me that during the test. It was test 5 back then, but he asked me during the test. Oh, good. It's funny. I'll give you. Yeah, you got a question? He raised his hand, he was sitting in the second row. Everybody's dead quiet, everybody's taking his hand. I walked over there and he says, is it all right if we touch ourselves? And I said, whatever it takes for you to get through the exam. I left it kind of generic, but you will see people in here and it's perfectly fine. I wouldn't worry about what other people think. Okay? Just don't show up with like a henna tattoo of all the muscles. You already thought of that, huh? Okay. He did ask me that during the test, and I found that rather funny. But it's your test, whatever it takes to get through it. Just don't touch anybody else. Okay. The distal end of the humerus is where we're going to see an articulation with the forearm bone, radius, the ulna. So that's technically what we call our elbow. So you have the lateral epicondyle, there's a lot of landmarks we gotta look at here. There's a lateral epicondyle and there's a medial epicondyle. The medial epicondyle is larger. Above that, just for reference, I showed you in green and purple there. Not so concerned about those, but above the lateral condyles there is the supracondylar ridge, medial and lateral. But it's more important for you to know the medial and lateral epicondyles. So if you look at even yourself, we're always in anatomical position. Your medial epicondyle, if you think of like when you hit your elbow and you go, oh, I hit my funny bone, that's your medial epicondyle over there. And then your lateral is not as easy to physically see, but it's out there. And so you come back to the skeleton and we have medial, which is larger, and then lateral epicondyle. Those are important attachment points for a lot of muscles of the forearm. When we look past that towards the middle there, we have the capitulum and the trochlea. So there's a rounded projection on the end of the humerus. Kind of looks like a marble. That is the capitulum. The trochlea that is found next to it immediately is here. And the trochlea kind of looks like a spool of thread. And multiple classes ago, I realized that nobody's doing anything for themselves anymore. I had to explain what a spool of thread was, because people didn't know. So when you have like a sewing machine, you know what how many people don't know what a spool of thread is? I'm being honest, because, so, you know what a barrel is, right? Yeah. So if you picture a small little barrel looking thing, and it's just you can just wind thread around it, and it has a hole through the middle, almost you could spin it around on that. And so the thread's on there, and it has a hole because you take it and you pop it on the top of a sewing machine and it feeds the thread. That's a spool of thread. So they say the trochlea looks like a spool of thread. I wouldn't go through that if people didn't say that all the time. It looks like a spool of thread. Doesn't to me, but it's basically kind of looks like this. Kind of goes in the middle. That's the trochlea. And I'll tell you, there's a reason why they're saying that. I'll show you. Whoops. Now, depressions. There's nothing that's not important. I've really whittled these slides down, so unless I say it's not important, I want you to know it. Because there are depressions. And I was doing a couple of CMEs, and I was doing it with my wife, and they were talking a lot about these depressions. Actually, I was doing a CME on the elbow, and that one I remember, and they were talking about things we don't even get close to. I was like amazed. There's an orthopedic surgeon doing it, and when he was talking, I was almost like somebody in here that's never heard of the elbow joint. I was like, all that's in there? I mean, obviously I knew a lot of it, but they were defining certain ridges and parts and how you shave it down 1 millimeter. You know what I mean? They were getting very specific, and I'm like, I better pay attention. There's a test at the end of this. Even though they come back and tell you the answers to them before the CME is over. It was interesting though. We don't get that deep. When we look at the lateral side, this is called the radial fossa. And on the medial side, you have the coronoid fossa. Now remember, there's a difference between the coracoid and the coronoid. Similar words, different things. These fossas are depressions. And so you would say that the radial fossa is above the capitulum, so it receives the head of the radius. The coronoid fossa is above the trochlea, so it receives what's called the ulnar conoid process. We haven't studied that yet. What it's saying is, if we look at the skeleton, this is our capitulum, this is the trochlea that's been kind of cut through there, and the radial head is here. So when you flex your forearm, your elbow, the radial head would be said that the radial fossa receives the head of the radius. Everybody kind of see that? It allows you to get more flexion at the elbow there. And it's going to help to stabilize it as it locks in, because it's going to go in, the radial head is going to go into a depression on the humerus. So you hit that bony block. Same thing with the trochlea portion, the ulnar coronary process. We'll get to that. Break time. No spark little for them. That's all we thought.
Same one at HEB because how it works is it comes with the blood, so it comes with 4 of the container that you actually collect the stuff in, and then you put it in the machine itself has an applicator that activates it to, and the top is the only thing you really have to clean is the top and it's not much, like on the actual machine itself, it's less like you Oh, college is nice. Actually, okay. College work. Those old school Tahoes were fucking like. I don't really think it makes me
That's why I left Chevy.
the thing in GMC is it's still GM. So it's like not really. GM is still like it looks like it's
I know what you're saying. Everything is said.
yeah. Because like you have dog, you have dog, you have a brain. But then if you like you want now, it's what's the it's like
Interest too.
no, like Toyota was made except for this new generation, the new generation like kind of like they decided to go a different way and it's not working out well. So prior to 2021, like they're these newer ones like bro, like I made them for like you have to check out the whole like my buddy just got and he was all like back like 2 years ago and he was telling me that like 27 is putting the southern energy into his head about that he's like I mean I did
I saw took the shit out
I probably just had it in there. I'll just probably add it in there since she's talking about it. I mean, it's when did you start your search? 18th of July.
Yeah, that's what I was gonna say. I don't know if there's like a formula like where you just go.
Leah's birthday, so we gotta sing happy birthday. Alright? They said, nobody noticed, so you gotta sing happy birthday. I will, right? Happy birthday to you. Happy birthday to you. Happy birthday to Leah. Happy birthday to you. I said it right. I said it louder for all y'all who are like, oh man. Well, happy birthday. Hope you have a good day. Glad it's not on the test day. I didn't take the night off. Just me. Just me. I'm all business when I was here. All right. Hopefully we're not going too fast. Anybody feel like we are? Hopefully you're seeing there's a lot of pointers I can help you with, but you gotta study a lot of this stuff to get it. Alright, bones are not the hardest part though, really. We already talked about this side, so we're kind of moving on to the electron ion. When we look at the electron ion, or what I used to refer to, and still do funny sometimes, as the holy granite. If you hit your funny bone, holy crap. It helped me to remember it, wordplay, but the electron ion. The electron ion is actually, we have to talk about with the forearm bones. When we look at the ulna, at the proximal portion of the ulna, there's an area called the electron ion that we find here, posteriorly. Right, that's the bony part of your elbow. That's UFC, right? Cut people's heads open with the electron ion. But there's a fossa, we're going to talk about here for saying there is an electron ion fossa. And when you look at the skeleton, where you have the electron ion of the ulna, and it has a depression or fossa on the humerus, it's called the electron ion fossa, and it receives the electron when you go into extension. That's why you can't go any further. If you do, you're going to break that. Break something. So what if you do break something? I like to discuss fractures when we first start talking about the extremities. And not in clinical stuff really, but most fractures when we look at the humerus are going to occur at the surgical neck or somewhere along that shaft close to that. And we have different types. If you have an impact fracture, that's where you drive the bone into each other. And you still have a fracture line, but it's not angulated or anything. So if you took these two bones at that point and you fell on it and just drove them together and it fractured, though it's still not having an angle, angulated. That's an impact fracture. It's relatively stable because nothing really moved there. Doesn't mean it's not painful, but most of the pain with that's going to be if you move it. If you hold it still, it's going to feel, not initially, but it will feel better. Right? Transverse fractures are where completely you have a blow to the side of that and you fracture straight through it. So if you have an angulated, or you have, let's say, a oblique fracture at the surgical neck, or in that shaft area, and it fractures all the way through, a lot of times it's going to be angled. Let's switch this down. It's going to angle because the deltoid is here. Remember the deltoid tuberosity that's down here? It's an insertion point. The deltoid pulls this way, right? And so if you break in that area, the deltoid muscle is going to pull that and angle that proximal portion of the humerus up. And so you have an angle fracture there, and it could be open or closed. I mean, it may come through the skin, or it could stay closed. Either way, it's going to bleed profusely, whether you can see it or not. Yes?
Like kind of like when a peg tears and it rolls up.
Oh, yeah.
Obviously, there's no bony attachment here, but like kind of same.
Yeah, the muscle has tone, like the pecs have tone, and when you sever or tear that while you're lifting, it's going to roll up. Or you tear your Achilles tendon, it's going to roll up. Here, it's just going to, the same thing would happen. If you separated the deltoid insertion point, it would roll up too. Which is like having one crazy muscle spasm. I can't even imagine the pain of having your Achilles fully torn. Anybody done that? Yeah. My brother-in-law did it, but he didn't tear all of it. Explain that later. I gotta save some stories. avulsion fracture. Anywhere in the body that a tendon attaches to bone, because tendons attach muscle to bone, rather than fracture the bone straight through, or rather than tear a tendon or a muscle, you can pull the attachment point up. You see this a lot with the lower extremity, and you talk about fibularis brevis, which goes to the side of the foot. Anybody's ever rolled their ankle, there's a tendon that attaches to the fifth digit there. Like I said, we'll talk about that in lower extremity. That can come loose. But anywhere, like where your rotator cuff, we're going to look at its attachment points, you can pull a tendon and it can pull part of the bone off. That's called an avulsion fracture. You know, I would think even an ortho goes in and screws those back down. Now, I think it's got to be better than tearing the tendon, because tendons have relatively little blood supply. They don't heal very well. And so if you tear that tendon, you're going to have to recover longer from that. And if they go back in and tack that tendon still has part of the bone on it, they can screw that in. So avulsion fracture may not be the worst fracture to have, because you can come back from that quicker. And I mentioned the acromion, right? Middle-aged, elderly, people my age and older. Right? My buddy I told y'all about, maybe I did. Yeah, he's old. Goodness, he looks old. I'm looking at that again. What have you done to yourself? It's a hard-living life. Think we'll be here. Fractures at the humerus can occur in different locations, and we learn things to remember them, especially when you go into radiology, going to ER medicine. You get a scenario, and they're going to tell you where the fracture's at. And so what I like to teach here, I just want you to know this, is well, if I fracture an area of the humerus, what is most likely to be damaged? Doesn't mean it will, right? Because we know millions of people, or not millions, but we know lots of people who fractured their humerus. They didn't have nerve damage, but the potential exists. So when they ask questions in emergency medicine or give you a scenario and they say, a person came in with a transverse fracture of the humerus at the surgical neck, what nerve is most likely could be damaged? You would say, well, that's the axillary nerve, right? The technical person would say, oh wait, there's 4 nerves that go through the arm. Couldn't you technically injure any of them? Yeah, this is textbook medicine. And what lies close to the shaft of the humerus is the axillary nerve at the surgical neck. Sorry, up higher. When you get into the shaft of the humerus, you would say radial nerve. When you get down to the distal end by the lateral and medial epicondyles, at the distal part you have the median nerve, and the medial epicondyle, the ulnar nerve. Right. So when we look at all these nerves later, when you find, like it's easier on yourself, if you feel medially in your medial epicondyle, just behind that, there's a kind of a notch there, right? A groove. And what runs through that, what you hit, when you hit that on something, you're actually hitting your ulnar nerve. Your median nerve, think of middle, it goes kind of down the middle. And then you have a radial nerve that's coming down towards the lateral epicondyle. And so if you damage the medial epicondyle, you have the potential to damage your ulnar nerve, not your median nerve. And that's why I'm spending a little bit of time on it, is because you'll ask, people say, well, there's a fracture of the medial epicondyle, what nerve might be damaged? The ulnar nerve. And what your mind wants to go to is the median nerve. The median nerve doesn't go by that medial epicondyle. Okay, bones of the forearm. Ulna and radius. We only have 2 of them. One on each upper extremity. The ulna's standing in anatomical position. The ulna is going to be the medial bone of the forearm. The radius will be the lateral bone. And you can always think about radial nerve. We'll get into the nerves, but doing a thumbs up, that's your radial side. C6 radius actually does cutaneous innervation, H2 we'll see later. So if you do a thumbs up, especially like this, that tells you that's your radius. that side. Or you can just remember which one's lateral and medial. So what's interesting about this that we don't often think of is that the ulna doesn't move, technically. The radius does. When we study pronation and supination, I'm going to show you the muscles that do that. But for now, if you stabilize the elbow, holding on to that ulna, this is your radius, thumb side, right? The radius is actually pulled up and over. And you'll get to see that in the lab with the extremities we have. You can see it here. We'll have ligaments that you can look at. This is coming up and over, so you can actually feel that if you're holding your elbow, this ulna that comes down this side, and you can turn that radius, and you can see the ulna doesn't really move, just radius. Just comes up and over. Pronation, supination. Pronation, supination. Remember, we're still anatomically. Alright, so we got to define landmarks on these bones. So the ulna we're going to start with. The proximal end of the ulna contains the olecranon, that bony part of our elbow, or the prominent part there. And then you have what's called the coronoid process. That's this area here. I'm going to use the same pictures for a lot of these. When we look at the proximal portion of the ulna, and we look at the olecranon and the coronoid process, that area is set to receive the trochlea. And right here in the middle, this kind of ridge, this is called the trochlear notch. They don't call it a ridge, they call it a notch, but it's, in the picture it would be kind of elevated towards us, so that now we can picture, and it's easy to see on the skeleton. Here's your trochlea, and then there's the coronoid process, and it's hard to do, and the olecranon's here. And so it kind of wraps around it, and there's a ridge between them, so the trochlea is kind of indented in the middle. That's why it looks like a spool of thread, and it rides in that. So you would say that the olecranon receives the trochlea. With all of these, you got to get on the skeleton and look at it. When you're studying these things, it helps you. Another portion that we find on the ulna's proximal side, proximal end, is the radial notch, or notch of the radius. That's found here. That is a depression on the ulna that receives the head of the radius. So we have two areas that actually receive the head of the radius. We have the radial fossa on the humerus when we're flexed, and we have the radial notch on the ulna that receives this head. So I'm going to tell you this ahead of time, and we'll look at it here in just a second. There's a radial notch there, and then there's a notch on the radius, an ulnar notch on the radius down here. When I talked about pronation and supination, that's where the motion is going to occur. So those become important articulations there. But for now, we're just kind of looking at what bones landmarks are. So you would find that just below the trochlea, the trochlear notch, coronoid there. But here below that, you find the ulnar tuberosity. And that's just an insertion point for the muscle of the arm. Down at the distal end of the ulna, the only thing we really need to look at, two things. We have the styloid process of the ulna. And then we have a disc that will be found here. It's not pictured there, but there's a disc there. And when you look at the wrist, this will make a whole lot more sense once we've done it all, but the radius articulates with the bones of the wrist. The ulna does not. And the distal portion of the ulna has a disc that sits between that area and the carpals, the wrist bones. So there's a fibrocartilaginous disc that's found in it. So by definition, they don't articulate, just the radius does. We'll see that more when we study the wrist. Just to the lateral side of that, or medial side of that, actually, if you find the pisiform bone, you can do that by looking at the crease where your hand creases, and one of the carpals there is called the pisiform. It's a rounded bone that we find here. And then you can feel down below, and if you're looking for that ulnar stolid process, it's kind of a bony part there. And between them, you can't feel it as well as the others, you have a ligament, the ulnar collateral ligament of the wrist. Anytime you hear collateral ligaments, you gotta know what joint you're talking about. Because the knee has collateral ligaments. Every interphalangeal joint has ulnar, or has medial and lateral collateral ligaments, right? So this is the ulnar collateral ligament of the wrist, and it would come off of this area here. And go to the area of the pisiform bone. Switch over to the radius. We have the head of the radius, which looks kind of like a tire. Actually, the head of radius has a ligament that looks like a tire. It's called the annular ligament. It goes around the radial head. So if we said, well, the head of the radius, where does it articulate? It articulates with the capitulum of the humerus, and then it articulates with the radial notch on the ulna. Where it articulates with that radial notch on the ulna is called the superior radial ulnar joint, ulnar radial joint. You can say it either way. And then just below that, we have the radial tuberosity. The radial tuberosity is where one of the muscles of the arm, anterior compartment of the arm, inserts. Obviously, I used to spend a lot more time here on that, but we'll get what we need. So let's drop down to the distal portion of the radius. This is called the radial styloid process. That one's very easy to find. And you can feel on yourself below your thumb, the radial styloid process, and if you do a thumbs up, sorry, I'll try to do mine. You can find your radial collateral ligament and some of the other tendons that run over that area. We're going to discuss that in detail. We're going to talk about the area there called the anatomical snuff box, but for now, there's a ligament that comes off there. That's that area, right? That wasn't your kid. Was it yours? I mean, I'm thinking and pointing, but did it involve that radial styloid? Somebody else has. Oh, it was when I was skiing. The girl had a goose injury while she was snowboarding that was with us. And she wasn't with her parents, so I had to go over to the clinic there with her. And she had fallen back as she was snowboarding. And they were all concerned that she fractured her scapula. But it was the radial styloid process. I'm going to stop because that's stories for later. Today's the day. I'm not killing all my stories ahead of time. I'm telling you twice. Then I don't have to ask you about it. Right, interosseous membrane. Between the bones of the upper and the lower extremity, forearm and leg portions, you have a tissue, a connective tissue membrane between them, and that is termed the interosseous membrane. That's what we see here. What the interosseous membrane does for us in learning separates your anterior and posterior compartments of the forearm. But it also provides an attachment point for a lot of the deeper muscles of the forearm. Meaning that some of the muscles of the forearm are going to originate off a bone, and part of it attaches or originates off of this interosseous membrane. And we'll just leave it at that for now. So like I said, we get back to this. To do pronation and supination requires muscles, but it also requires these two joints. So you have the radial notch of the ulna, you have the ulnar notch of the radius that we see here. And where they come together, the radius articulating proximally. This is your proximal radial ulnar joint, and this is your distal radial ulnar joint. like I said before, that's what allows you to rotate, on the long axis, what we call pronation and supination. And you don't want to have a problem with those. Now we're going to see this picture a lot, especially as we talk about the carpals, the wrist bones. But the first thing I like to cover is the dorsal tubercle of the radius. Because when you first start looking at a picture like this, the radius, the ribs, it's not always as familiar as it will be. One of the ways you want to figure out is, let's say we're studying the carpal bones of the wrist. I'm going to teach you to them in rows, and you learn them from like medial to lateral. But if you don't know where you're located, you will confuse them. So they kind of look the same on a picture. And so one of the first things you can do, because you learn a certain way, is orientate the picture and say, well, am I on a posterior view or an anterior view? And so this picture is a posterior view. Because on all of us, if you feel, we're in anatomical position, so this is posterior. But if I bring it up like this, you can actually feel the ends of the bones, but right here, in the middle almost, you can feel kind of like a raised area. And that's called the dorsal tubercle, or Lister's tubercle. Lister got famous, I guess he said, hey, I'm going to call that the dorsal tubercle of the wrist. And so you have that found on the radius. This is your radius, and this is your ulna. And where that disc sat earlier I talked about would be here. So look for this ridge, Lister's tubercle, dorsal tubercle. That tells you this is a posterior tubercle. It's not the only thing that tells you that, but it's a good one. So if that's a posterior view, then we can orientate and say, well, if the radius is over here, which digit does this have to be? The thumb. Thumb's on the radius side. So hopefully that'll help you later with orientating them. I am going to later show you that when you look at extensor pollicis longus tendon, the long extensor of the thumb, as it means, it actually uses Lister's tubercle to make an abrupt turn. So it uses it like a pulley, not really a pulley, but a way to increase mechanical advantage. And if you pop your wrist up, or sorry, your thumb up and your wrist at the same time, a lot of times you can see the extensor pollicis there, and you can trace it back to Lister's tubercle where it makes that turn. I know you can't see my hand, but you have to kind of run that on yourself, and you can pop that up. Wow. Okay, this last thing we're going to talk about today. We're going to finish the bones in the hand, and tomorrow we'll come back and start with the bone, the muscle of the posterior back. We'll get into some muscle. Bones of the hand, you have 8 carpal bones, you have 5 metacarpals, then you have 14 phalanges. And so what we're looking at is like taking a skeleton and saying, okay, well these are the 8 carpals, and then you have 5 metacarpals, and then you have your phalanges. Well, you have 14 phalanges because these are different bones. Right? You have 5 digits, but you only have 14 phalanges. Because digits 2 through 4 is phalanges, you have a proximal, a middle, and a distal. You have 3 phalanges on each digit, but the thumb only has 2. So that gives us 14. Same thing in the foot. Okay, learning your carpals. When we look at these, we're going to label them and say, what's the proximal row, what's the distal row? It does not help you to know the proximal and distal rows in order if you don't orientate the image. Throwing that out there to you. That's why I started with orientating. Because they're all jumbled up. They kind of look the same. A lot of them sound the same. The first one we're going to look at, we're going to go from lateral to medial in this case. Here's lateral, this is medial. We know that's lateral because the thumb's out there. Thumb's always lateral. So I'm just going to put a line as I talk about it. This is the scaphoid, the all-important scaphoid. Now I could care less if you know what shape they are. The shapes are there to help you learn them. I never really memorized the shapes. I memorized which carpal bone was which in order. So there's the scaphoid. We're going to talk a lot about the scaphoid because it's more important than the others. Next to that, in the proximal row, you have the lunate, and then you have a couple of small bones. This one's called the triquetrum, and this round one is the pisiform. We're going to go back, go to our distal row lateral medial, and the first bone that we see here is the trapezium, and then you have the trapezoid, the capitate, and then the hamate, the hamate. Has my ham hanging on a hook. The hamate has a hook. I'm going to give you some generalities to help you out here. The scaphoid, you'll know because we talked about it. Generalities. The scaphoid and the lunate articulate with the radius at the wrist. The rest of them are just wrist bones. Ways to remember these, the hardest part that you're going to have is which one is the triquetrum, which one is the trapezoid, which one is trapezium. Unless you're very good at looking at pictures and going, yeah, that looks more like a trapezoid and that looks more like a you're not. It's just a memory thing. So the way you're going to figure out which one is one of the 3 T's of the wrist bones is you have to learn them in order and know whether you're anterior or posterior view. That makes sense, right? I read a statement that said that if you want to sound more professional, you shouldn't say, does that make sense? It said you should rephrase that and say, would you like further explanation on that? Or would you like further clarification? That's totally uncharacteristic for me. I'm more of, does that make sense? When I say, you already know me. When I say, does that make sense, that's your opportunity to go, that makes sense at all. I don't understand a thing coming out of your mouth. But y'all never do that. So, working good so far. All right, whether it makes sense or not, because y'all are honest and go, it's gonna make sense once you're important. Okay. The hands. Stop letting those people touch the cadaver's hand. I think you can come up with a better mnemonic than that. But when it's the hand, I can think of all sorts of things. I'm not going to give you my mnemonics. But, in this example, they're going lateral to medial, and this picture is what view? Posterior view. You can see the facial tubercle. This picture is an anterior view. Now you can clearly see why you will get them out of order if you don't know the orientation of the picture. Right. Another thing you look for in rows, there's the hook of the hamate. Pisiform's an easy one because it's round. So really, once again, before we move on, that's what's going to trip you up is the 3 T's. And here's just a labeling picture, study picture, learning which carpal is which. The only other time we're going to come back and talk about these is the scaphoid. But you do need to know the carpals. Then we get to our metacarpals and phalanges. Our metacarpals, we have 5 of them. Those 5 bones, if you think about the palm of your hand, the bones on the back side of the palm of your hand, not really on the back, but where you can feel the bone better, is the metacarpals. Right? So you have 5 metacarpals. 1, 2, 3, 4, 5. So they're numbered from the thumb to the pinky. In this picture, they have it essentially pronated because normally you're like this. Right? So they're pronated there. So they start with the thumb. 1, 2, 3, 4, 5th digit being your pinky. Each one of these has, I won't draw on all of them, but each one of these has a base, the shaft, and then the head. I'm going to say this on the same topic. Each of your phalanges has a base, a shaft, and a head. Keep think of any reason why we would wanna delineate or spell that out? And radiology. Radiology, you get a report that says you have a fracture of the base of the fifth metacarpal. Almost said tarsal. Fracture of the base of the fifth metacarpal. Now you know exactly where that's at. You have a fracture of the shaft of the fifth metacarpal. How are you gonna get a shaft of the fifth metacarpal? Metacarpal? That's your punching, right? That's the one you break. That's that person who thinks they're gonna hit that bag that, I don't know what they call it, the punching bag that goes up and it rings how much you get. Oh, we're gonna be like you never seen one of those. Urban cowboy. Right? You ever seen somebody hit one of those that doesn't know how to hit something? I'm like, you just know they're gonna fracture that. Did y'all do that recently?
Let's just say you walked out of the room.
Oh. You seen those video and Instagram videos where they're like big, they're like, I'm gonna kill this thing, and they swing and they completely miss it? Oh, that's that what he did?
He hit the machine.
I've seen that too. Did he fracture anything? That's awesome. Because where do they know? I'm not saying him. We're gonna forget about him. A lot of people, where do we find these machines?
Bars.
In the bar. Fuck. Anyway, that's great. I don't know why I walked out of the room, though. That's funny. Okay. Phalanges. What's that?
So he may have felt some silent judgment from the side of the room.
But that's the thing you're going to remember most about being here all this time, is those things. Same thing with life. Alright. Phalanges. You only have 2 in the thumb, that's why we have 14. I want to go back and talk about joints real quick. You have your metacarpals, you have your carpals, and then you have your phalanges. The joint between your metacarpal and your phalanges is appropriately named the metacarpal phalangeal joint. That's these joints here, where these meet. Then you have, joints that are between each phalange. So each phalange where it meets has a joint, and they're called interphalangeal joints. And so this joint, I'll draw a different one. This would be my proximal interphalangeal joint, my PIP. This would be your distal interphalangeal joint, which would be your DIP. And in the thumb, you only have one joint there, and that's just simply called a interphalangeal joint. So that's it. It's funny, they often call these, you'll hear the metacarpal phalangeal joints in textbooks. They call, like you're not in textbooks, but when people are teaching, they'll say, well, this is your door knocking muscle, door knocking joint. Never got that, because I knock on the door with my PIP. I don't know about you. You know, you knock like that, that's the police knock. I'm up there. You home? I'm hoping not. Tell me to come by, I'm hoping you're not here. I don't treat you like that. I'm gonna leave y'all with this for the day. Nobody got it. I'm sitting at a table eating with people, and I said, Joe, I came out on Facebook. They're like, what do you mean? I told you I posted a picture, right? Did I tell you that? Oh Lord. See, that old guy made me. I went, and years ago I told you I took a picture of my counter. I didn't tell you any of this, I thought I did. So Facebook told me I needed a profile picture like years ago. And so I just turned around, I got this blue countertop, and I took a picture of the countertop. I've saved it because I've got idiots. I've had it on there up until a couple of days ago. Idiots, within 2 seconds of putting that picture on there, they were trying to guess what it was. They're like I'm gonna tell, I just never answered a single one of them. They're probably still wondering to this day. Picture my counter. I didn't do it so I could talk to you. I got a little, this is gonna make me sound like a nerd, but that's fine. Is that I was thinking about the friends, I said, you know what, I'm gonna let these people find me.